a Barnard class of 1969, and I'm the chair of Project Continuum Committee of the Alumni Association of Barnard College. The mission of Project Continuum is to bring together Barnard alumni who graduated 30 or more years ago to promote dialogue around diverse personal, professional, cultural, and political issues. As a quick reminder, Zoom participants will not have microphone or camera access during this online event. Attendees' voices, likenesses, and/or images will not be captured by Barnard College. Written submission of questions, please, may be shared during the Q&A portion of the event. It is my pleasure to hand our program over to our featured speakers to introduce themselves. So I think Janice.
There we go. Yes. So I'm Janice Horowitz, and I actually transferred to Barnard from Smith College. And it was one of the really the best decisions of my life. I loved the joyous intellectuality of Barnard. I loved taking classes throughout the university. There was this saying at Smith that girls went to Smith boring and came out interesting. And at Barnard, the young women came in interesting and left even more interesting. Probably the best thing that happened at Barnard was meeting one of my very best friends, who I'm still friends with today. And I really think that speaks to sort of what Barnard's about: great women and just something very genuine and real. Professionally, I covered health at Time magazine for more than 2 decades. And I think the reason I was invited here is that I wrote a book called Health Yourself, which looks at your care from the day you're born until old age. And what I tried to do in the book is help people, and I'll go into it later, to get the best possible care they can. Did you want me to introduce the next person?
I think Kathy's next.
Oh, hello, can you hear me? Hi, my name is Cathryn Devons, and I'm from the class of 1982 at Barnard. I went into Barnard as a psychology major, interested in becoming a teacher, and left interested in medicine and interested in geriatrics as a career as a result of my exposure to courses that I took at Barnard and people that I met there, developed my interest in medicine. I'm currently a geriatrician practicing at Mount Sinai in the Martha Stewart Center for Living, and also at Phelps Northwell in Sleepy Hollow, where I also practice geriatrics.
Hi, everybody. I am Lesley Sharp. Welcome to this event. It's nice to see there's such a great turnout for this. I am currently the chair of anthropology at Barnard. I have been here since 1994. It was my second job after graduate school, and as far as I was concerned, it was the dream job, and it has remained that ever since. I've had opportunities to leave, and every time I say no, because I love my job here. I am a medical anthropologist by training, which means that a lot of my work has focused on health, healing, illness in cross-cultural perspective. But I have spent the bulk of my career looking at biomedicine from a critical perspective, thinking critical meaning theoretically, and thinking carefully, especially in all sorts of domains, whether it's my original work in Madagascar to current research in prisons and in scientific laboratories about end-of-life issues. So much of my work is focused on the cheery subject of death and dying, memorialization and remembrance, but also just thinking really carefully and comprehensively about how we move to the phase of end of life in really remarkable kinds of ways, and how we think carefully and in moral and ethical terms about what that means for ourselves and for others.
Thank you all for joining us to share your unique perspectives on defining care as we age. Starting with Janice, would you share with us what you do and how you frame the concept of care, please? You're muted.
Well, what I would want to talk about is how I think the posture of a patient should be. And, it starts with this idea that we go to a doctor and we want to be the good patient. We nod, we smile, we accept what we're told, we want to be liked. And that's fine some of the time. But how I, in a sense, define care is also how a patient should be, their perspective and what they bring to that medical encounter. And this is really what my book is about. And I want to at least have a chance, it's a short time, to give a flavor of what one's perspective should be when you're at a doctor's office, and really questions to ask. It's a time when you should really be thinking and analyzing and churning in your head all the time about, what's going on. So one of the things that I like to talk about that really reflects your perspective is something that I think will always benefit you when you're at a doctor. And that is what's getting a second perspective. And basically that's a twist on a second opinion. We all know that second opinions are valuable. It's been drilled into us kind of forever. And it's amazing how valuable second opinions are. 35% of the time, a second opinion will yield a different treatment. And a whopping, I think, 15% of the time, it'll yield a different diagnosis. But there's a way to boost this up, and that is what I call a second perspective. And I'll just digress for a moment to tell a story about my daughter, to explain what I mean by second perspective. She woke up one morning and had a giant round rash on her stomach. And she didn't want to go to school until she went to the doctor. And we raced to an early morning appointment with the doctor, who took one look and said, it's Lyme disease. Meantime, it was February. And when she got there, we both saw there was another rash on her shoulder. And he said, there's been, I'm like, it's February. And he said, there's probably been a tick in her belly button since the summer. And I still was sort of suspicious of the way we all get that like little nagging thing. I'm not so sure. Are you right? Aren't you right? Okay, maybe you're right. I said, well, she's never had any flu-like symptoms. And I swear the rash has gotten smaller since the morning. He said, she's got 2 rashes. This is very serious. I would want her on IV antibiotics, but instead I'll prescribe a high dose. Give it to her immediately. And I didn't quite buy it. And I sent her to school, and I thought I must think about this. I must do something. And I felt I had to get somebody else to weigh in. But I didn't go to the pediatrician down the hall, and I didn't go to a friend's pediatrician. I went to a dermatologist, and the dermatologist said, this is hives, and gave her an antihistamine, and it vanished by the evening. And, I might have said to myself, if she took those antibiotics, wow, that really works well. She responded so well, but all of it wasn't necessary. So for patients, what does that mean? I suggest going to a doctor in a different but related field. For example, if you have a shoulder problem, you can go to an orthopedist who's a bone specialist, and you could go to a different doctor in a related field like a physiatrist. The reason is different specialties have different training. They go by different guidelines of their associations, and they see a different patient pool. So you can run down the list for a headache, a neurologist, and a pain doctor. It's not so hard to come up with a related but different field. So another thing to bring a kind of healthy skepticism to your doctor appointment. Sometimes I use my book and say a health yourself skepticism, but it's fine. You know, it's okay to talk to your doctor and ask questions. Let's say you're prescribed a medication. You might be told that this medication cuts in half the risk of something bad happen, let's say coronary artery disease. So that's like a big thing, cuts 50% in half, you want to take that pill. But that's not always really what you want to know. It's a bit of incomplete information. What you want to know is what is your risk without any medication and with medication. It's actually called the absolute risk. So let's say your risk for this really bad thing is only 2%, and the medication cuts it in half down to 1%. This is a time when you should ask your doctor, is it worth it? Is it worth the side effects, the cost, the compliance, that you have to keep remembering to take this pill to, yes, cut 2% in half to 1%, but you're only moving the needle 1 percentage point. So there are other questions that I think allow you to be a healthy skeptic and still be a nice person, a nice patient. And that is when I go to a doctor, and it's not so much in New York, because New York doctors are a little more savvy, I guess. I scan the office and look for mugs or pads or pens that are emblazoned with the name of a drug. And if those are there, you might think that your doctor was visited by an eager salesman or had gone to a conference. That's fine. But if your doctor prescribes that drug, or really any drug, you might want to ask if there's an older drug that works just as well. So why is that? For a new drug to come to market, you only need a few thousand, or in clinical trials, there are usually just a few thousand subjects. Once a drug is out on the market, thousands of people with all kinds of backgrounds and imponderables and on all kinds of medications are exposed to the drug. So doctors become more familiar with side effects, and they know how well it works, and they know what to do about side effects. And unfortunately, there's sort of a double whammy for seniors, and that is, it's not merely just a few thousand people might be used, or the drug might have been tested on a few thousand people. It may actually be no seniors, 0 seniors in the clinical trial. And the FDA has been concerned about this actually for decades. And today, half of all clinical trials have upper age limits. And it puts doctors in a bind. I mean, you want to prescribe a medicine. You don't want to deprive a patient, a senior patient, of a medicine, and you don't want to cause harm. So if a doctor prescribes a medicine, and again, you need to kind of have courage, you might ask, how much experience do you have prescribing this medicine to my age bracket? But you can avoid all that, actually, if you go to a geriatrician, and we have one here this evening. Geriatricians are not that common. They're difficult to find. They're sort of rare, wonderful beings. So the way around that is to try to find a primary care doctor whose specialty would expose them to older people. For example, cardiologists.
Janice,
A lot of
sorry, I hate to cut you off, but I think it's time for our geriatrician.
Okay, go.
A good transfer
One
point. Thank you.
final thing is just keep at it, practice, and you'll be great at asking questions.
Thank you, Kathy. Thank you.
Thanks so much, and thanks for the vote of confidence in geriatricians. What I was hoping to cover with my few minutes is to talk a little bit about how the population is aging, about how important I think geriatrics and geriatricians are, something about preventive health for older people, and also making the most of that doctor visit, making the most of the time you have with whatever doctor you have. So I'll start with a little bit about demographics of aging. There are currently 56 million people in America that are over the age of 65. That's 1 in 6 or 16%. This number is expected to double by the year 2060. And not only are older people growing rapidly, but the percentage of people that are reaching very, very old age is increasing the most rapidly. If we look at centenarians, right now, there are 100,000 people over the age of 100 in America. And by the way, 85% of those people are women. By 2060, that's not very long from now, we're expecting 600,000 centenarians in America alone as the baby boomers reach 100. So as a geriatrician, our goal is, of course, to extend life, but not only to extend life, but of course, to extend quality of life. We're trying to keep people happy, healthy, productive, and of course, well cared for. What are geriatricians, and do you need a geriatrician? Well, geriatricians are doctors that don't just focus on one organ. We're primary care doctors. We're interested in every aspect of our patients' health, the physical health, their psychological health, and of course their social health. And any one of these on its own is not really sufficient. And everywhere I work, we have a social worker helping us, because if we prescribe medicine and the patient has no way to afford it or to obtain it, it really doesn't help. We try to take into account individual desires of the patients for their care and their special needs. As people get older, they probably become more and more different from one another, and there really isn't a formula for what exactly the care that we prescribe for people. If you have a 5-year-old and you're a pediatrician, there might be a particular formula for which vaccinations, what kind of tests you might do, but for an 85-year-old, it could vary enormously. So I care for people in offices, in hospitals, now telehealth since COVID. And most importantly, I find the care that I deliver to people in their own home to be the most helpful to them. People that are homebound, that cannot get out to the doctor, that have no other access to care without me coming to their home. And that's roughly how I spend about half of my time, caring for people that cannot get out of the house, that need help. We have a range of patients coming into our practice. We have healthy people that are just becoming older, that are really looking to focus on preventive health. And then we have the older people that are maybe at the end of their life, where the focus is on hospice and palliative care. And I try to stay with my patients right through to the end. And if they go on hospice, I continue to be their doctor, so they don't have to have a new doctor at the end, and I go to the house and care for them. So because I've been in geriatrics for 30 years, I've seen many people, from people in their 60s to people in their 90s, and tried to see them through, their life and their needs as they came up. My focus is on function, on maintaining independence, and those sorts of goals. I don't think everybody needs a geriatrician, but common reasons why people do seek out a geriatrician, the common causes of the visits Memory loss is probably the most common. They've been to their primary care doctor. They've expressed concern about memory, and that's a huge problem that really opens up Pandora's box. And a lot of primary care doctors just do not have the time or the resources to help those sort of people. And they often come to geriatricians for help. People with experiencing falls, incontinence, polypharmacy, which is the prescription of too many medicines, going to a lot of different specialists. That happens a lot in Manhattan. They go to their cardiologist, they go to the endocrinologist, they go to infectious disease, they go to multiple doctors for multiple things. They end up getting medications from a lot of different doctors that may conflict with each other, interact, be duplicate of, 2 different medicines for blood pressure. So that's really, really important to sort of hone down the medications and make sure they're suitable. Depression is a big problem in aging, osteoporosis. Those are kind of some of the main kind of medical problems that people seem to seek out geriatricians for. At Mount Sinai, we start taking patients at 75. We just don't have the resources really to, for the most part, deal with older people, unless they're experiencing problems, maybe like an early onset Alzheimer's or something where they really need our expertise. Our average age is somewhere in 87 years old, people that we see. They tend to be the frail elderly with the complex medical problems. A typical patient, that I might see would be a 90-year-old who's got diabetes, hypertension, dementia, and just had a UTI and has now fallen and broken a hip. Really lots of complicated problems that need caring for. I think you touched upon the fact that we're a rare breed. There are 7,300 geriatricians in America. If you do the math, if every older person had a geriatrician, we only have 1 geriatrician for every 10,000 people in America. So we're in short supply. But one of the things that we really try to do is try to teach specialists, work with specialists and try to help them understand the needs of older people and how to care for them. We work with geriatric fellows. We work with medical residents. Every resident at both hospitals that I work with has to rotate through geriatrics. We try to explain to them how most, or many of their patients, unless they're in pediatrics or obstetrics, are going to be elderly, and how to care for those people. And we teach all the medical students coming through. All Mount Sinai medical students have mandatory rotations in geriatrics. So we try to spread the word and have doctors in every specialty understand geriatrics. So if I have a few more minutes, I can start to talk about preventive health. There are 2 types of preventive health that are important really at any age, but in geriatrics, we think of primary prevention, preventing disease from happening in the first place. Things like diet and exercise and taking good care of yourself, of course, could prevent heart disease as you get older. There are also things that you might need a physician for in order to practice primary prevention. Preventing, the big example of that is vaccinations, flu shots, pneumonia vaccines, tetanus, diphtheria, and pertussis vaccine, shingles vaccines, COVID vaccines. Those are all illnesses that can be prevented from happening by getting vaccinations, and a great deal. Then we also have secondary prevention. That's early detection of disease. So it doesn't prevent something from happening, but it helps us pick it up early. And this is something that probably is somewhat age dependent. When we advise somebody to do something, it depends on where they're at, what their desires are, what their life expectancy is. But for instance, doing a mammogram for early detection of breast cancer, doing a bone density, looking for osteoporosis, colonoscopy, trying to catch colon cancer early, doing a pap test. Those are all early detection. We also try to, check blood pressure, cholesterol, diabetes, look for those things to prevent future complications. Lastly, I kind of in the preventive health category, I always think in my mind when I'm seeing patients about advanced directives. talking to every patient about their wishes for care as they get older, encouraging people to designate a healthcare proxy, a proxy that understands what their wishes are for care if they can't express it anymore, so that we as physicians can administer the care that they would want, and that they're represented and we understand that. So try very hard with every patient at the first visit to explain about advanced directives, encourage them when they're well, not in a crisis situation when they're old, but when they're well and they can think about it, who they would want to represent them, what kinds of care would they want at the end of their life, and how can I represent them well.
Thank you, Kathy.
Am I out of time?
Yes, we'll hand it over to Professor
Okay.
Sharp.
Thanks, you two. You've given me a lot to think about here. So I'm going to approach this question of defining care as we age from a slightly different angle. As an anthropologist, I'm trained to think in social terms. And so I'm going to confine myself to that and maybe provide some ways that we might think outside the box in terms of our own personal lives and desires and hopes and dreams for how we age and how we're cared for. To give you a sense of sort of where I am, I graduated from college in 1978 and I finished graduate school in 1990. So I'm now in my, mid approaching late 60s. And my long-term friends, who I think of as members of I think of them as my age mates. We spent a lot of time talking about how we imagine our futures in terms of the precariousness of growing old. A number of us, for instance, do not have partners and like living that way. We really enjoy our independence, and independence is already a theme that's been touched on here. And so I'm going to be talking, part of what I'm going to be talking about is going to be framed by this desire for independence, however it is you might define that. So you're also going to find that I'm going to be focused on sort of end of life and the nature of the definitions of care. So what it is that we're hoping for and the relevance of the social in the mix of all of this. So a common desire for many of us, for very independent women, for instance, is to be able to age independently. And when the end time comes near, to be able to often to die in place, meaning we want to be at home. We don't want to be in a hospital, or we don't want to be in an institution of some sort, but sometimes that is necessary and sometimes we opt for that too, right? I have very good friends who are already planning for where they're going to live in terms of assisted living and that sort of thing. But there's also, I think there are anxieties that many of us share, which is who will be there to care for us when we were there, when we are, approaching the end times, so to speak. And one of the things that Kathy said that really resonates with this is you'll see that when I'm talking about sort of your social world, it can include your physician or social worker or other people. It can include professionals. But I'm going to focus on another aspect of that, which is that a pervasive assumption that we have when we have conversations with others is that we're going to have kin, we're going to have family members who are going to be there to provide for us, to provide the supportive care that we need, that sort of thing. But not all of us have that, right? We may not have offspring, we may not have partners, we may not have siblings around who either are available or want to, or that we may want or not want around as the ones who are in charge of our lives. And one of the things that we're finding that we know very well in anthropology is that whereas there is this emphasis on kin as the default of people to take care of you, there are all sorts of other ways in which to do this. And the most important category here that's non-kin involves friendship, right? Involves our friends. And so again, if I go back to my long-term set of friends who are my age mates, we talk about this among ourselves. What is it that we're going to be doing as a way to care for one another? And just to give you a personal example, I got COVID last month for the first time after working very hard to avoid it. And what I found, and I got pretty darn sick. I got sicker than I can remember ever being, even though I was, vaccinated and had all my boosters and was very careful and everything else. And one thing that really struck me was how many people reached out to make sure I was okay. Friends who were local, who were national, who were even international, because I had been in Denmark just before then. And so I had a lot of people who were checking in on me, and, and neighbors and my dog walker and lots of people. And so it made me realize, okay, I'm actually pretty well bolstered here in terms of my non-kin networks. And I want to hold on to that. I want to think of that, not just in terms of I have people who care about me, right? But also maybe I should be thinking about this as a strategy. So, and I think that friendship can be just as important as financial planning and medical plans and legal plans. And so I want to suggest that we play with this a bit. So if we look at the anthropological data that, studies that are done by medical anthropologists, one thing that's emerging is that friends can often be a hidden workforce in terms of taking care of those who are in need. And we're especially seeing this, for instance, in cases of dementia, because especially with advanced dementia, Alzheimer's, whatever, different forms of dementia, sometimes will retreat because there's this feeling that the person that I love and I know is quote unquote no longer there. That's a problematic phrase, but it's something that we hear a lot. And I speak as a daughter of someone who had dementia, had advanced dementia. And friends don't necessarily respond in the same way. And so we see friends who are stepping in on a daily or a weekly or a monthly basis or whatever, sometimes even rotating in terms of their understanding care as a moral project, right? That one invests in one's friendships throughout one's life and doesn't abandon friends when, for instance, we're very, very ill, we're chronically ill, or maybe we have dementia. Second thing is we tend to rely, if we can afford it or we can get the resources for it, if we want to age in place, we rely on home healthcare workers. And this is especially true where I live in New York City. And so I want all of us to be thinking about how complicated these relationships are, right? This is a hired professional who often is asked, unfortunately, to do all sorts of other things that are not part of the job description. So it's very, very easy to exploit and to take advantage or to forget that there are certain boundaries in terms of the profession of that, what that person is there for. And I think another thing that we know from anthropological work, anthropological studies of home healthcare, is that the person who's being cared for often feels vulnerable and can even feel abandoned by their kin. And sometimes we take that out on the home healthcare worker. And so I want everybody to be thinking about this in advance in terms of this isn't just a very complicated situation, but it is one that has enormous possibilities for ways that we can think about. You are taking care of me, and I am here to take care of you too. I honor you as a human being and as a person, and you're not my servant. You are here actually to ensure the possibility of my independence, right? So to go into those relationships, thinking carefully and critically about what this should be as opposed to what we might be turning it into. And then finally, so this is my sort of out of the box part. And I'm going back to my age mates. How might we think creatively and critically about, the end time and the end days? And so I'm just going to throw out a few things. These are the kinds of things that I do. One is I've started to realize maybe I need to start making friends with people who are younger than I am, right? Because I think our lives are about sort of this accumulation of friends over time. And I have people who are very dear to me who are my age and who are older than I am, but they may not be around when I am in need of care and compassion and that kind of thing. And so it makes sense to be making friends with people who are younger than we are. Similarly, I think it's important to be working with physicians and other healthcare providers who are younger than we are. Because I myself, I've had 2 physicians retire on me and I miss them terribly. And I realized, oh, one of them said, you need to get someone who's younger than I am. And she was right, right? So that's something that I think about. A second is that why don't we make pacts with each other, right? Why don't we make arrangements ahead of time with each other that we will check in with each other on a regular basis, like all of my COVID friends did. And, some people have really sort of creative, kooky strategies, like every day I will put this teddy bear in the window and you will know that I am all right. But, not to make, belittle that at all, but maybe they're just basic things that we do that signal for our neighbors who are walking by or driving by, friends who are on the block if you live in a suburban neighborhood. What kinds of things can we do that I will let you know that I am okay? And then finally, maybe we should be thinking about creating creative arrangements, living arrangements as we age. So when I was in my 20s and my 30s, I belong, I'm sort of that hippie era. I was a member of various cooperative households. And one of those groups of people are still, they're friends for life. We will do absolutely anything for each other. And I imagine myself as moving back to where most of them have stayed, because I know that I can be there for them and they can be there for me. And then an even more radical idea is, again, my age mates, several of us have been thinking very seriously, what if we invested in property where we live together?
Lesley, I'm so sorry.
And
I'm so sorry to cut you off.
I'm at the end.
Good.
At the very end.
Thank you.
How do we think
everyone was wonderful. We thought it would be interesting for the panelists to ask questions of each other before we go to your questions. So Janice, I think we will start with you. You had a question. You're muted.
Yes, for
Thank
Dr.
you.
Devons.
Thank you.
I think you mentioned that you have patients in their 80s and there's no real guideline. I think you said that. And the question is this art of being a doctor, what do you do about this fact that often seniors are not in clinical trials, even for things that are geared to seniors, like TVAR, like a special, for years, instead of opening up a person's chest, you can kind of insert almost like a stent, a new valve. But that's a procedure thing. For medication, how do you do it? Do you ever go even below a dose that a clinical trial, maybe for blood pressure, because the elderly are prone to falling, and blood pressure medication, lowering blood pressure, can make you dizzy. So how do you navigate through all that?
Excuse me, you're absolutely right. If you look at the package inserts, many of the drugs that we prescribe actually do not include older people in their trials, and they're mostly tested on younger people. So I think one thing you mentioned about maybe not using the things that are just out on the market that doctors don't have a lot of experience, that drug companies are trying to push you to prescribe, more use the ones that we have more experience with, that are tried and true. The other sort of motto of geriatrics is to start low and go slow. So generally we do, especially for, smaller people and older people, prescribe half the dose, a quarter the dose. You could always go up on it, to try just a little bit. The antidepressants, we'll go, what's the lowest dose? And I'll say, I'm just going to try you on literally half the lowest dose that's usually given, and see how that goes. So you start low and you go slow, and you make multiple appointments and you say, let's try something. blood pressure pill, whatever. We're going to try a very tiny dose, and then you come back in 2 weeks. We'll see how it is, and then we can increase it a little bit. But it's much better for somebody to walk around with their blood pressure being slightly high than to go too low and they fall down and hurt themselves. So
you actually cut in half the dose that's studied, right? So that's
very often. I mean, not every time, but very often.
Try it. You'll try that.
A hefty 65-year-old, you know, that's got hypertension, you probably could start at the, you know, the regular dose. You know, a frail 90-year-old, you know, weighs 100 pounds, you start at half or sometimes even less than that of the usual dose. And closely follow. The other thing that really helps is to closely follow people. You can't have people leave you, you know, prescribe something and say, come back in 6 months and we'll see how it went. You just can't do that. You come back next, you know, in a week or 2 weeks. So closely follow people, start low and go slow, I say, and use the medications that you're familiar with, more the tried and true than jumping to the latest thing on the market that you don't have experience with. You know, let it sit for a little bit and make sure it's okay.
May I just ask, I mean, do you think a regular internist would cut a dose in half? You know, presented with an frail 100-pound 85.
I mean, I think you mentioned
Or
that
you need the specialist.
internists that deal with a lot of older people would probably have that experience. Many internists, you know, who needs doctors is mostly frail older people, not, you know, healthy 30-year-olds are wouldn't normally be running that often. But I'd say if you choose an internist that has experience with older people, they should probably know that. You know, we're in New York City, so of course there's a lot of people that are specializing in everything. If you go to somewhere else in the country, maybe they wouldn't have that expertise, but hopefully whoever you choose as a physician would be thoughtful about what they're giving and give a very small amount to start.
Thank you. Anyone else, any other panelists have a question for any of the others? Lesley, please.
I just want to say, Cathy, I found two things that you said were really interesting. So the first touches on what Janice, I think, is getting at too. This idea of polypharmacy. I found that very helpful to actually have a name for it, because
Has a name for taking too many medicines, being at risk for side effects. One thing that's really important is when you go to any doctor to bring a list of all your medications with you. It sounds kind of obvious, but lots of times people come in and they don't remember the names of all the medicines they're on and the dosage to write down or just put them all in a shopping bag and bring it all along. That's also that's even more helpful because you could see who prescribed what, you know, you look for the names on the bottles and you see where it's come from, but you get multiple doctors prescribing for the same thing. Somebody has a headache and they go to 3 doctors and mention it. They may get 3 different types of pills. 2 of them may be the same. One has got the generic name and one's got a brand name of something very similar. And you can make yourself sick from taking too much stuff. And nobody is sort of steering the ship. And
another element of that, of polypharma, is that you will take a drug, you get a side effect, and then you take a drug for the side effect, right?
Exactly.
And
Take
then
a water
another
pill
drug
for your
for the other
hypertension,
side
and then
effect,
take
and you're
and
a walking chemistry experiment.
Right. You take a water pill for your blood pressure, and then you start to get incontinence, and then somebody gives you a medicine for incontinence, and then you get a dry mouth, and then somebody's giving you something for that. That's exactly like, go back and let's just use something for the blood pressure that doesn't make you urinate all the time, you know?
Yeah.
So, yeah.
Right. I have a comment related to that. I mean, I don't know, Cathy, whether you must be in one of the systems, because a lot of my husband has a lot of doctors and a lot of medicines, and you know, and they're all in Connect. I don't think they always, you know, they're all in the Connect system.
Yeah.
I don't think, unfortunately, all the doctors look at them, but they're all there, which is, I think, is a big step forward.
Yeah,
Right,
it's important
exactly.
for the doctor to look to see what your other specialists are doing and finding.
Right.
It could be somewhat time consuming, but not
Yes.
every computer system seems to exactly communicate with the other one. And so
Yes,
you can't 100% be sure that
agreed.
that chest x-ray that you had at one hospital, that I can see it from another hospital. And you know, if you can get if you can get it on your phone from your app, or you can print off a copy of the
Right.
result, it's really helpful because it also prevents repeating a lot of tests, going to multiple doctors, complaining the same thing. And people start ordering the same thing over and over again because they don't know what the other one's doing.
Right.
There's also an issue with that, which it's worth sitting with your doctor and going through those medications because they kind of stay there forever. So even if you stop taking something, it's still in that Connect or the portals or, different hospitals. So it's worth the 10 minutes or 5 minutes to say, I stopped taking the sleeping pill. I mean, anyhow, so those things have to be reviewed every once in a while.
Yeah. Or people start on something and everybody's afraid to stop it because they're not sure why it was started or by whom. And so people just keep repeating over and over unnecessary drugs. And
Right.
So
So
I think something we might want to pay attention to too is that there are questions in the chat.
Yes, so I was about
And,
to start with
we've
that.
been talking about medications, but that's not
Right.
necessarily what the questions
Right.
are about. But one footnote I want to add is that the idea of the physician who comes to the house is just absolutely marvelous. And many of us can remember when we were children that we had doctors who made house calls, and that this doesn't happen anymore. The only physician I see these days is my podiatrist, who always no, because the podiatrist
Great.
services people who are not ambulatory and who are aging, right? And so I love this idea of expanding that so that we go back to this world where the physician comes to us, because it makes them, they see you in your home. It must make a tremendous difference, I would think, Kathy, if you actually are seeing somebody at home. So
I spend about half my time seeing people at home, and I'll tell you, there's so many people that cannot get out because they're bed bound, they've had a stroke, and they just don't get any care until there's an emergency. So nobody is checking on them, making sure they're taking the right medicine, checking if they're getting wounds, if if their diabetes is controlled until there's a crisis and an ambulance is called. They're just simply not getting care. So I spend about half my time going to people's houses. I also see exactly what's going on, what their needs are, what equipment they have or don't have, how they get out, what medicines they're taking. Are they able to take them? Are they taking them correctly? Like, it's all right there. So it just speaks 1,000
That is
words.
wonderful.
You're very noble. There also, people can take, well, two things, and I know Sinai has this, Martha Stewart Center, is if you don't have such a noble doctor, you have PAs, physician assistants, who sometimes are more available. You can call them on their cell and they make house calls. You may not be getting an MD, but for simple things like wounds. And the other thing is a lot of stuff in telemedicine has become much more sophisticated. My mother, to be personal, had an aortic valve replacement, and she was able to put a machine to her chest and have the data transmitted electronically and have it checked. So there are ways to help people who can't get to an office, and it's really a matter of asking.
So we do have a couple of questions in the chat, which I'd like to throw out for anyone to answer, please. So the first one is, seems that aging in place is typically the mantra these days, but living in a senior residence gives you community and activities. So why is aging in place always the thing that is promoted? Anyone?
Oh, I did answer that. I did answer that.
Okay.
I think it's regional, actually. I think
Regional? Okay.
Yeah, I think it's
Okay.
regional. I mean, I think it's really pronounced in New York City. It's one of the things that really surprised me when I moved here, because I'm not a New Yorker. But it depends. It depends, I think, on where you grew up in the first place, where you imagine you want to be. Not everyone wants to die in their apartment in New York City, right? So there's a tremendous amount of movement of seniors in this country and abroad, with the idea that they're joining communities that are specifically for seniors. And so, no, we need to be keeping that in mind, right?
Okay. I'm sorry if I'm repeating anything, because I was actually thrown out of the webinar at one point and had to get back in. So apologies.
I think I've been typing some answers, but I think when I answer it, the answer disappears. I'm not sure where the answer is going to.
Okay. Well, let me try the next one, and you can tell me if you've done this one, if anyone's done this already. Are medical schools and residency programs producing more geriatricians for the foreseeable future?
No.
No, that's okay. I guess that.
An answer. I mean, it's a pay scale thing that
Right.
they say geriatricians, when they get out of medical school, don't make as much as their peers, and it's hard work.
Mhm.
You know, a radiologist who can look at a scan for 5 minutes makes more than you do on a house call, or a pediatrician does in 15 minutes. There's an economic dynamic going on. If it's fair.
Cathy, do you want to comment?
Yeah, I mean, society needs to recognize probably the importance of what we do. It's exactly,
Mhm.
you know, you go to a dermatologist and they remove something off your skin for 5 minutes and they charge 5 times what, you know, what a primary care doctor gets.
Yes.
They don't get all the satisfaction we get, but they probably can make more money. I mean, we do try to train people to be aware of geriatrics, but there is a great deal of need for people to go into the field. And there are certainly many that are interested in the field of palliative care is growing a great deal. But there needs to be, you know, we need more.
Mhm. Right.
Don't know
So-
if it's really growing commensurate with the increase in the population aging.
Mhm. Right. So there was a question about long-term care, which might in a way be endless. You know, what if a spouse doesn't have long-term care and dealing with it? You know, that is a problem. I think those of us who did not get long-term, care are all insurance are all dealing with. So that in a way might be kind of an endless conversation. I know that you can still get it at 75. It just costs a lot more. Let me just go to I think the last question. Do you have suggestions on how to age well or recommendations for specific interventions to promote healthy aging? And I could give one answer to that because someone asked me this question this morning, because my father died in September 2020, 2 months short of 105. And someone said, how did he do it? And I said, he had a martini every night before dinner. But now I leave it to you to answer.
Well, you need to choose your parents well and make sure that you've got good genes. And I have one word, but it's your area, exercise. That's my little.
Yes, I agree. Anyone
Always
else
helps, it
suggestions?
can't hurt.
Sorry?
Always helps. There's no,
Yes.
unless you hurt your knees and your back. But even
Right.
even running is good for your knees, shockingly. It brings
Right.
circulation.
All right. Anyone else want to throw a suggestion out? No. Okay. Well, I want to thank everyone. I want to thank Janice, Lesley, and Cathy for joining us and being such terrific speakers and giving their perspectives. And I'm sorry that we had a little bit of a glitch in the morning, but at the beginning, and we look forward to seeing you at the next event. So thank you all very much. And thank you for the attendees as well. Thanks a lot.
Thank
Bye-bye.
you.
Bye.
Yeah.
all.
Bye.